is one part of the team, and the aspect of care that you saw in that video can't happen from one person. This is one aspect where everybody really needs to come together to make a good experience, a positive experience. So my task tonight was to actually, in about 20 minutes, maybe a little more, to cover all of amputation surgery. Not really possible, but I do want to focus on three things that I think the surgeon has a very key role in. That is decision making, performing the surgery, doing surgical technique, being reconstructive, being positive. And the last one, which many surgeons sometimes get and sometimes don't, is attitude. And I would say the little medical student tip at the bottom is, of those three, I think the surgery is the easiest, which many people kind of go, huh? The decision making is actually very difficult sometimes. And maintaining and coaching and being positive in the attitude can be very tough. In the decision making, one of the things that we need to realize is that there are a lot of reasons that people end up facing limb loss, having amputations. Diabetic foot from infections or ulcerations or osteomyelitis. Vascular disease, when you lose the circulation to a limb. You get ischemia, loss of circulation. And you can get rest pain. Muscle hurts when it doesn't get oxygen. That's why heart attacks hurt. Likewise, legs can hurt. And gangrene. Tissue can die, tissue can mummify. You can actually have dead tissue attached to you. That's gangrene. And we have people that face these very difficult things all the time. Those top two are probably some of the nationwide, the highest reasons people lose limbs. High energy trauma, as you saw from the video, burn injuries, frostbite. We're getting more and more in this country severe necrotizing infections, necrotizing fasciitis. The media sometimes calls it flesh-eating bacteria. At Harborview, we used to see one, maybe two a year, and then it went to one a month and two a month. We probably see one or two patients a week at our own center here in Harborview of necrotizing infections now. So Mother Nature is getting very aggressive. People lose limbs from cancer, congenital issues, severe deformities, and dysfunction and pain. They've had an injury, they had reconstruction, and it never worked out. And I sit down almost every week with people saying, would my life be better with an amputation if I gave up this foot that just doesn't work? And we have some pretty interesting discussions about the pluses and minuses of all that. So as a medical student, you need to learn about these different areas and some of the things and attributes of each. When I have those discussions, when someone actually is facing limb loss, I often say, you're in a spot no one ever ought to be in. And it's really true. Giving up a limb or having to decide to give up a limb. And one of my mentors, Sigvard Hansen, who is the former chair of Orthopaedics and is still very active in his foot and ankle practice, taught me back in 1989, there are certain discussions you never have standing up. First thing you do is find a chair and sit down. And I think that's one of the best lessons I ever learned from Sig Hansen, is that there are certain times, as medical students, as doctors, we need to sit down and catch our breath and realize this is not an easy conversation for them or for us as healthcare providers. And I think that was a lesson that I have tried to always maintain, is that there are certain times as a healthcare provider, you just need to sit down and really sit and talk. The reality of amputation, something my kids have said to me occasionally, something sucks. Amputation sucks. It is difficult. There are a lot of downsides. Even though you see on the media someone running with President Bush, a soldier who is rehabbed to do something amazing, a mountain climber with 2 amputations, a skier that has returned to skiing. You see the positive, but deep down, it's no fun to wake up missing an arm or a leg. And I think we can't overlook that that is a real thing. There's a real functional loss, there's a real change in body image, and there's often pain that goes with limb loss. There's things like phantom pain, this mysterious thing of if the part's gone, how can it still hurt? And yet the computer that runs your arm or leg is still there, and you can still feel your arm or leg even though it's missing, and it can even hurt even though it's missing. The good side, surgery, prosthetics, rehab, they are much better than 20 years ago. That is really good. One thing that in our amputee clinic at Harborview has been really fascinating to me is, and you need to be aware, there's a changing attitude that happened around the year 2000, 2001, 2002, where before that time we would sit and talk with people, And they were coming forward with the attitude that amputation is absolutely the worst thing in the world. I would rather do anything than lose my limb. Any surgery, any reconstruction, what can we do? Because I never want to go there. That attitude was probably too far one way, because amputation in many cases made people's lives better. It allowed more function, allowed them to heal, get rid of an infection, start feeling better, start rehabbing. Interestingly, in the last few years, because of the media and you see a computer leg on TV, we actually have people coming in often believing amputation is a little better than it is. And I've had people that have real problems, but not to the scope that traditionally lead to amputation. They're saying, I broke my ankle, it never healed quite right, it really is sore, and I want an amputation and an artificial foot. And sometimes we step back and have to catch our breath a little bit. And it's very interesting that there is this changing attitude. I think it's good because it highlights we're doing a good job with rehab and surgery, and we are making people better. But it's almost like the pendulum went from too far one way to too far the other. And I think as healthcare providers and medical students, we need to be aware that there is this attitude out there, and you have to understand where the patient's coming from. Is the patient coming from the point of view where they're scared to death of this and their view is worse than reality? Or is their point of view, which is a new one for me, that they're coming at it with an attitude that is actually better than we can give them, and we have to kind of bring them back to earth a little bit. And so this has been new in our clinic, and we've been talking about it more, but it really is very interesting. In decision making, when I sit with people, I think there's actually two situations that you have to be aware of and try and decide which one you're in. There are times when salvage, saving the limb, is not really possible. Sometimes it happens fast. This accident this summer that you saw in the video, there was no choice. His leg couldn't be saved. To save his life, all these things had to be done to stop the bleeding. There was nothing that could be done. Sometimes we see people with infections that are so bad surgery needs to be done fairly rapidly, and there's really no choice. But other times people are coming in, and a great example is a lot of the folks that get diabetic foot infections, where it's really starting to make them sick. It's really starting to impact the rest of their health. And it has kind of reached the point where, as a surgeon, I look at it and really realize it's kind of past the tipping point where the foot can't really be saved. But the family and the individual haven't quite gotten there. And one of my jobs is helping them sometimes realize there really isn't a choice. So there are situations where it's pretty clear amputation is the right thing and needs to be done, but you have to work sometimes fast, sometimes slow, over a week, 2 weeks, or a month, to help get people to the point where they can make an incredibly tough decision. And we do a lot of that by outlining the plans for surgery and rehabilitation. An even tougher spot is when they really do have a choice, and they are trying to choose between more salvage surgery and living in the pain that goes with it, or amputation and rehab. And the option trying to sort out, would my life be better with, is a really tough one, and it takes a lot of education. It's where the support groups really help, the nursing education, the prosthetic education, having people go to a prosthetic shop and touch and feel a leg, and meet other people that have been through this. The interesting thing that took me a while to learn, and orthopedic surgeons, we can be a little slow, and sometimes it takes us a while to get things, but the point number 2 under the med student tips, first one, you have to realize, are you in a situation there is really a choice or not, to help counsel them. But the second one is, it took me a while to figure out that most people think about salvage, they automatically think salvage equals normal. And there's a big hurdle to say, if we keep going with saving your limb, there are going to be these real limitations. And trying to accurately help people understand that is interesting. But this concept, salvage equals normal, took me a while to figure out that that's what the patients were bringing forward to me. And it was my job to help kind of talk about that. When we get into the surgery itself, there's some things that really have to be done. You have to remove diseased and damaged tissue. We try very, very hard to preserve functional joints, like a knee joint, like an elbow joint. And we talk about the amputation levels. We'll have a diagram here in a minute. We need to reconstruct a limb. Someone will be using their arm in a way that was never invented. Someone will be walking on their leg in a way that God never invented that leg to be walked on. We have to craft the bone, the muscle, the padding to give them a new interface with the environment. So amputation is actually very reconstructive surgery. We are building a new way to touch the world. And we have to create as a team situations for very positive rehab, moving from rehabilitation and including prosthetics and therapy. And as medical students, students will need to learn all the details of the different levels. And here's just a skeleton that highlights 12 or 14 different amputation levels. And each one has unique anatomy and situations. So obviously we can't cover everything, but people lose limbs, all the way to the chest wall, sometimes called forequarter. They lose not just their arm, but their clavicle and their scapula, and they just have rib cage left. Sometimes people just lose a hand at the wrist. So there's all these different things that are really unique and different. And for our example tonight, we're going to talk about one of the most common amputations, which is an amputation below the knee. And it's interesting because you have limbs that have very little padding and the bone sticking out. You have other limbs that are padded in this fashion and in this fashion. And I'm going to highlight through some of this that one of our goals is not to end up with the bone sticking out and the bones prominent. We want things padded. We want them reconstructed so that they can work with a prosthesis. When I'm teaching our residents, and where we really get into surgery detail is in the residency, when the residents are helping us with the decisions in clinic and helping us in the operating room with the surgery, and gradually doing a little bit more as time goes on between their first year and their fifth year of surgery. But we talk about the plan before surgery. How are we going to make skin incisions and flaps? What are we going to do with the nerves? What are we going to do with the blood vessels? How are we going to handle the muscles, the bones, and how are we going to get everything closed at the end? The handout has a lot of things that we're not going to cover, but I'm going to kind of clip through these different things just to give you an idea of some of the things we think about. The pre-op plan. Where do you cut the bone? What makes sense? Historically, people used to just put their finger on a bump called our tibial tubercle and put their hand down and cut the bone there. And for decades, people always cut the leg at that level, which is about, depending on your hand, 12 to 16 centimeters. And everybody's hand is different. That really didn't make a lot of sense. But that's how it was taught for decades. And interestingly, even when I came out here in the 80s, many people still had that approach. Now we recognize the value of longer tibias, but not too long. When you get down to the lowest quarter and third of your leg, there's very little padding. How are you going to cover that with tissue that can tolerate someone's whole body weight? So what is a perfect solution? Well, it turns out somewhere in the mid to just shorter of mid-tibia makes sense, because you've got this great muscle in the back of your leg, the calf muscles, the soleus and the gastroc muscle that can be redesigned as padding. But we also have to think about space. Technology can't fit into just an inch. And many of the padding, the socket, the connector, the cool foot and ankle that you see in some high-tech magazine now, for low impact things, you need about 3 or 4 inches between the end of the limb and the ground. And for some of the really interesting stuff that many of the soldiers are using, you need about 6 to 9 inches. So you have to leave enough space to allow technology to work. So a practical length often is about 1/3 to half the length of the tibia. Much shorter than many of our patients realize when they come in and you show them where you're going to do the surgery. They go, oh my, I didn't think it would be that high up. And then you have to explain why and what the goals are with the padding.